And everyone can be seated. Make them pay anything.
Dr. Myers, as part of your evaluation, were you able to determine a diagnosis, that your own independent diagnosis for Ms. Schenecker?
Yes, I have, and that would be bipolar disorder with psychotic features.
What's your opinion about bipolar 1 disorder with psychotic features versus her potentially having schizoaffective disorder?
I've gone back and forth between those two throughout my review of this case and meeting with her. And I say that because every time I've seen her, she's had a type of thought disorder that's very typically specific to schizophrenia, which is thought blocking, where she'll be talking, then her thoughts stop, and she doesn't know where she was. She can't pull up the rest of the sentence, and it's gone. That's very commonly seen as far as mental illnesses and schizophrenia. And I saw that in Ms. Schenecker every time I met with her. So that was one of the things that was hanging me up on the schizoaffective diagnosis. But in totality, I think bipolar disorder with psychotic features fits best.
And how did you come to that opinion?
Partly because when she's been maximized in her treatment, when she's been on the best combination of medications to help her, and in between the episodes, she seems to be very high functioning.
When you spoke to Ms. Schenecker and also with your review of her records, were there times that you saw evidence of the psychotic features or psychotic symptoms?
Yes, there were, particularly beginning in 2001 and then up till the time of her arrest. There was periodically references in the notes throughout that period of time of delusional thinking, of sometimes having hallucinations, and of having a thought disorder or problems with the way your thinking is being done in your mind, reflected by how your speech comes out.
Tell me when you first observed anything like that in the records that you used for your diagnosis.
The first time would have been when she was admitted in the treatment program at NIH back in 2001. She had a delusion while she was admitted there that she had a brain tumor, which was what was causing her depression. And even after she had the brain scan, which the doctor showed to her, look, there's no brain tumor in your brain. Great news, you don't have a brain tumor. She continued to hold that belief for a time that she still had a brain tumor, and that would be an example of a delusion.
What can you tell me about that time when she was at NIH and her treatment there? What kind of treatment did she undergo when she was at that location?
She went there to enter into a study of somewhat experimental at that time, and it really is still being researched, but it's where you apply magnetic currents to the brain to try to treat depression. Transcranial magnetic stimulation, or TMS is what it's called. And what happened is they gave her this treatment, and she developed signs of mania from it, which is something you have to watch out for when you treat depression in people with bipolar. When you give them biological treatments, they can overshoot and go into mania and even psychosis, which is what happened with her.
Now, when you're treating somebody with bipolar 1, is that the type of patient that you're familiar with in your history, your work history?
Yes.
When you're treating a patient like that with the mood disorders, what are the medications designed to do that a patient is given?
In bipolar?
Yes, for bipolar 1.
To try to keep people in the normal range of mood fluctuation by giving them mood stabilizers.
Do those mood stabilizers try to stabilize the mania as well as the depression?
right, to try to contain both the highs and the lows from not going to extremes where it interrupts your functioning, your ability to think, your ability to stay connected to reality. And when she left NIH, National Institute of Health, from that study, she was on 5 mood stabilizers to control her mood, as well as an antipsychotic medication at a high dose. It took them months and months to get her stabilized.
Now, when a patient or a person wants to try to enter a study like that, or at NIH, would she have to qualify for that study?
Yes, she would, and then she would be evaluated very closely from pretty much all angles as far as mental health, her functioning, her symptoms.
Did they take her off of her medication initially at NIH?
They did, yes.
And what was the course of treatment? What was the purpose of taking her off her medications at that time?
So you can get an idea of whether you don't want her to be on a medication and then give her a treatment. And then if she gets better, you don't know if it's the medication she was on kicking in or the treatment that you're giving. So you want the person to be off all medications when you try a new treatment in a research study like that.
And how did she do, or how was she doing when she went off of her medication at that time?
As I recall from the records, I don't have a complete set. I have summaries, but it sounds like she was depressed and the medications weren't working very well. Basically, the medicines weren't working, I think, is how it's put in the records.
When she entered the treatment, how long did she stay in the treatment?
9 or 10 months.
During that course, did you were talking about the delusions being her thought that she had a brain tumor that was causing her depression. Was there any other psychotic symptoms that you observed from the records during her time at NIH?
Yes, she also developed paranoia, suspiciousness, as well as she became what they described as having mania. And so, and she had been given an antidepressant, and it was around Christmas time she was discharged from the unit for the break, and she stopped. She was on an antidepressant and on an antipsychotic medication, and she cut back on those over the Christmas break, and she came back and she was manic, very high, abnormally so, and so they stopped her antidepressant medications, which they thought might be pushing her up into mania, and they gave her an antipsychotic medication. And for a while, she actually had to be put in seclusion multiple times to control her behavior.
And was there any evidence at that time during the records that there was any alcohol involved with her treatment, or that she was using alcohol at that time?
No, there was no substance abuse problems mentioned.
When she was there at NIH and they're studying her closely, did they come up with a diagnosis for her at NIH?
Yes, they did.
And what was their diagnosis that they gave her?
It would have been bipolar disorder, and she had psychotic features.
What is an antipsychotic medication designed to do?
To treat psychosis or any kind of detachment from reality, as I mentioned before, be it delusional thinking, be it hallucinations, or a thought disorder, problems getting thinking clearly.
In Ms. Schenecker's case, is her mental illness or a brain disorder something that can be treated without medication?
No, it's not. The primary treatment for bipolar disorder and psychosis is biologically based or medications. You can't use talk therapy or psychotherapy and talk anybody out of a psychosis or a manic state or severe depression.
When someone is in a manic state, what is typical of manic type behavior?
Racing thoughts, poor judgment, engaging in dangerous or reckless behaviors you wouldn't normally get involved in, not needing much in the way of sleep, getting very involved, for instance, in goal-directed behaviors like maybe setting out to write a book or invent things, as an example, in fact, in her history.
Was there a history of her having thoughts like that about inventing?
Yes, she had a manic episode with psychotic features. I believe it was in 2006, 2007, and part of the history talked about her when she was manic. She was going to invent things that had to do with UV sterilization and types of water, and I think there was something to do with, it's not clear in the record, something about baby alarms. Very odd topics that I'd never seen before in the records about her, that she's suddenly going to do inventions in these areas.
And when she mentioned that, was that a way that she was indicating that she was going to potentially support herself financially with an invention?
Correct. And it's grandiose thinking, a grandiose delusion that I can go out and I'm going to invent these things and I'm going to make money and be able to support myself, even though in reality, from what I understand, she doesn't really have any background in UV sterilization, for instance.
Was there other evidence of grandiose thinking that you were able to discern from the records?
It would have to do when she went on, for instance, spending sprees. And I believe she was in Maryland. There was one period of time where she went out and spent something like $10,000 on some sort of pyramid scheme or some Amway program that apparently was a loss of money, a poor judgment related to mania. Also gambling, when it appears to be when she would get hypomanic or manic, she would gamble and she would believe that she was going to win.
Is it unusual for gambling to be associated with mania or hypomania?
No, actually it's not. It's that it fits pretty well with mania, because you go into the casino and it's a very stimulating environment and there's lots of noise and lights flashing and the allure of making unlimited amounts of money because you're lucky and you're special and you're grandiose, and it's going to happen for you because you're in a manic state.
Can you explain to the jury the difference? You're talking about hypomania and mania. What is the difference between the two of those?
Level of degree. Hypomania meaning sort of a smaller mania, not a full-blown mania, but still an abnormally elevated mood.
The grandiose thinking, is that something that is associated with psychosis, or is that associated with mania or depression?
You can have grandiosity with mania. If it gets severe, it's going to cross the boundary and be delusional. That is, it's going to be false, fixed beliefs about something that isn't based on reality. But it's a matter of degree. Whereas in depression, you tend to go the other way and have very low self-esteem, feel worthless, feel hopeless, feel like you're of no good to anybody. So it's sort of the opposite of grandiosity, depression.
In the records, there's a lot of conversation or notes about feeling helpless or hopeless. What does that mean as far as evaluating somebody?
Well, in somebody with bipolar disorder, when you hear them using words like, or the doctors putting down descriptors, helplessness, hopelessness, worthlessness, guilt feelings, that's indicating that they're going down into a clinical depression, or they're there, already there. Suicidality is another common one.
When you were reviewing the records, were there any, when she was at NIH, were there any other issues with psychotic features or mania at that time that you observed?
The other issue in the records I recall is that she was actually trying to escape from the facility, which would fit with her being paranoid and suspicious of the treater's intentions towards her.
And this would have been
even though she's really a voluntary patient, she's trying to escape. which I thought was unusual. So she's lost her judgment, she's lost her ability to understand the reality of the situation around her.
After her time in NIH, did you observe any other times from the records that you determined were features, psychotic features?
There was approximately, for my review, about 20 different references to psychotic symptoms or more between 2001 up until the end of 2010. And it would be in the areas of delusional thinking, of less frequently hallucinations, and then documentation in the records periodically of disturbed thinking or thought disorder. For instance, they would describe her as confused or circumstantial in her thoughts. That is, she's speaking, but she's not getting to the point. Or they would describe her having thought blocking, where she would be talking, then she would just stop talking, which is a thought disorder example. Or another one would have been superficial content in her speech, that there wasn't much in the way of depth to her speech at times. There's an emptiness to it.
Were there times when her speaking was what can be described as tangential?
Tangential?
Yes.
Yes, that was just described as well.
Explain what that means to the jury.
When you're talking to a patient and you are discussing a topic with them, you might be talking about, I don't know, we could talk, let's say, a glass of orange juice, and then they might go off on a tangent and start talking about glass, the orange juice is in a glass, and then something about sand, where glass comes from, and they would just keep going off on tangents and maybe never getting around to the point of finishing the discussion about orange juice. And so they're tangential. They just take off on a tangent and they don't come back to what you were discussing with them.
Is that typical for someone that has a thought disorder?
It's a common form of thought disorder in people with schizophrenia or other psychotic illnesses.
When a patient is being treated and you see the records that Ms. Schenecker has, explain to the jury the significance of continuity of care for a patient.
It's crucial. It's a must in patients who have a severe form of bipolar disorder. If they come off their medications, chances are they're going to get sick, and it isn't necessarily going to be a very long time, particularly in somebody who's had repeated episodes that have included psychotic experiences. So when they come off their medications, it's not necessarily if they're going to get sick, but it's when is it going to happen again and how bad it's going to be when it comes back.
Were there times when Ms. Schenecker became paranoid?
Yes, there were.
And what did you observe from the records about the times when she became paranoid?
Well, there was, as I mentioned, that was documented at NIH, and then in 2006, around that time when she was being treated in Bethesda, Maryland, there was documentation of paranoid thinking. For instance, in 2000, even as well into 2009, there's further evidence of paranoid thinking, but it would involve concerns with conspiracy against her. She asked one time when she was in the doctor's office if there were cameras in the office videotaping them. She complained that she thought maybe Parker had put video cameras in the home, and this had been something she'd been concerned about for a couple of years. Those were examples of paranoid thinking.
Was that something that you saw throughout the years, the paranoid thinking?
Yes, and it's something that seemed to come and go, fluctuate with the level of her illness and her medication combination at that time.
Now, when you're treating psychiatrists and you're able to prescribe medication as well as, treating the patient, how do you determine when to change someone's medication, add medication? How do you do that as a practicing psychiatrist?
What you hope for is that you get somebody on a stable level of one medication and it works, and you follow them and everything goes well. Unfortunately, that's not necessarily the norm in more difficult cases of bipolar disorder. So then what you're doing is you're doing your best as time goes on and following their symptoms to keep their medicines as well adjusted as you can. It can be particularly tricky, as in Ms. Schenecker's case, for instance. She was put on an antidepressant called Wellbutrin in 2006, and soon after that she started hearing auditory hallucinations. So if you're the doctor and you're giving somebody an antidepressant and they start getting psychotic symptoms, now you've got to take that medication away and try to come up with something else to treat the depression.
Is it a fluctuating process? It's not as easy as giving somebody one medication and that works. It's different for everybody.
Right. I mean, there's a proportion of people with bipolar disorder that are very, very difficult to treat, and their course is very complicated, and that's maybe 10 to 20% of people with bipolar. Then there's another group of people in the middle that do pretty well with medications. Occasionally they'll have some rough times, and there's another group of people that do quite well on medications, even though they have a severe mental illness.
And how would you describe where Ms. Schenecker falls within those type of patients that have bipolar 1?
She's more towards the refractory end of the spectrum, meaning that just about any combination of medication she's ever been on, she's had trouble staying stable on those medications.
And is that included time when she's been in a more controlled environment like NIH?
Yes. I mean, I can't recall the last time I saw a patient who needed 5 different mood stabilizers and an antipsychotic to control them.
When Ms. Schenecker started her treatment at USF, what was her condition at that time when she began her treatment in 2007?
She was coming out of a bipolar disorder with psychotic features episode when she came down to Florida and started the clinic there. I'm trying to recall the specifics of her symptoms right at that time. I know that they lowered her antipsychotic medication. I believe it was her Abilify, somewhere around 2008 going into 2009, and she started getting some more problems, more mental health symptoms, I believe it was paranoia around 2009, and so they had to go back up, right? That was when she had the cameras in the room concerned, so they had to go back up on her antipsychotic medication in 2009.
So they're changing her medication at that time based on the symptoms that she is describing as far as the paranoia?
Yes, and there was also some symptoms described that were manic in nature, some grandiosity.
How did that manifest itself with her at that time, the grandiosity?
One of her grandiose thoughts was that she felt like she had to get pregnant and create a baby and then give the baby up for adoption to atone for an abortion she'd had in the past.
Now, is that the first time that there's been indications about her speaking about getting pregnant?
No. There was a record in 2009 from USF where she told her doctor that in the past she had a belief, and she had thought about this for some time, that she was going to take her psychiatrist's comb, this was a past psychiatrist, and use the comb and get DNA from the comb and then use that DNA to impregnate herself in order to have a baby.
How would you describe that type of thought?
Psychotic thinking.
When someone is having psychotic thinking, is it something necessarily that you can see visually if you're face to face with an individual?
No, you would have no idea just looking at someone if they're having hallucinations or delusional thinking. You can't tell.
Can you explain how that happens to a jury, that you can see somebody and they appear normal, but they're having psychotic thinking?
It would just be like any of us looking at anybody else in this courtroom and trying to figure out what somebody sitting over there is thinking. You can't do it, or what their thoughts are right now. It's impossible.
When someone is having psychotic thinking, or is it something where that would automatically render her incapable of doing daily tasks?
It would depend on the type of psychosis it was. If you have delusional thinking in certain areas, it may not affect your ability to do other things. Like it may not affect your ability to get dressed or to mow the lawn or to drive your car or go shopping. Nonetheless, you still may be having severe delusional thoughts that are going around with you wherever you go during your daily life.
And at the time when she's exhibiting delusional thinking from time to time in the records, that's when, the majority of the time is when she's at her psychiatrist's office.
Right. And the notes are just glimpses of her mental status over the years. It's the tip of the iceberg of what's going on in her life. It's what's being documented in these notes.
And would that indicate to you, since it's in the psychiatrist's notes, that somehow she arrived at the doctor's office, arrived for the appointment, and went to the appointment and left, even though she's having delusional or psychotic thinking?
I'm sorry, can you say that again?
Is she able to do a routine task of going to the doctor's office, attending that visit, driving to the office, getting there at whatever time she was supposed to be there, while still having psychotic thinking?
Yes, that's right. And yet she is able to communicate to the doctors the symptoms she is having, be it depression or manic symptoms or psychotic thinking.
Are you familiar with the program at USF?
I am, yes.
Okay. And how are you?
Or at least I
familiar with
was
that?
until 4 or 5 years ago when I was working there last.
And explain why you're familiar with the program.
I was with the Department of Psychiatry there for close to 5 years. And I used to see patients there. I taught residents there. I ran the forensic psychiatry division there. So
The treatment, the psychiatrists that were seeing Ms. Schenecker during that time frame, the 2007 to 2011, can you describe how that program works and what kind of psychiatrist she would be encountering?
Well, from my understanding, she was seeing a different resident every 6 months to a year, depending on the cycle of the residents moving ahead in the program. So a resident would come in once they, let's say, hit the 3rd year, and they would go to the outpatient psychiatry rotation. So they'd go to the outpatient clinic, and the resident before them would hand over some number of patients that they were carrying, and then that resident would graduate to another level of the program. And then, for instance, Dr. Obregon came in I guess it was July, and then he would be taking care of those patients probably throughout that year. And then when he went to his 4th year of psychiatry training, another resident would take over.
When a patient in that program goes from one doctor to the other, are they able to have access to the other records from the prior psychiatrist at USF that was seeing that individual?
Yes, they are.
Was there a therapy component that Ms. Schenecker was also involved with?
There was, yes. She was also attending individual therapy.
How long was that going on, that she was seeing a therapist as well as a psychiatrist?
Throughout, as I recall, most of her treatment at USF, she had seen Beth Marsh for a while, and then she went to a different therapist, and then she went back to seeing Beth Marsh.
Is Beth Marsh someone that you're familiar with from your time at USF?
Yes, I worked with Beth Marsh when I was there.
And when someone goes in to see a psychiatrist and then a therapist, what is the role of the psychiatrist in the psychiatrist session versus the therapist session?
Well, it's designed to be complementary, where the psychiatrists can more maximize their ability to do the biological end of the treatments, and then the therapist is dealing more with the psychotherapy parts, the issues of daily living or interpersonal relations problems a person may be having.
When a psychiatrist is doing their evaluation, is it time constrained in any fashion when they're conducting their evaluation at USF?
How do you mean?
Like, are they setting appointments every 30 minutes or every hour? Is there an indication for the records how often or how long the sessions were with the psychiatrist?
I mean, it would vary, as I recall. The more complex the patient and the patient's needs, the longer you would see them, and the more frequently you would have appointments. I mean, the psychiatrist has control over that based on the patient's needs.
When you're treating somebody with bipolar 1 with psychotic features, is alcohol use or even drug use at times, is that unusual to see with somebody that's been diagnosed or suffers from bipolar 1 disorder?
No, 60% of people with bipolar disorder will have substance abuse problems. It's the norm rather than the exception. And there's different theories for that one of them is that they're self-treating the mental pain they're having from their illness. Another theory is that particularly when they're manic and high, they're not worried, nothing matters, everything's fine, and they're excitement seeking, so they drink or use drugs in that aspect of their illness. And another one is that they're just, for some reason, biologically vulnerable to substance abuse from the bipolar disorder.
In treating somebody that has bipolar 1 disorder and also, may drink alcohol or have issues with drugs, how does that affect the treatment, or how do you deal with that treatment?
You treat the bipolar disorder and get the bipolar disorder as well treated as you can, and then hopefully the substance abuse problem is secondary, and once you get their mood stabilized, they're not psychotic, the substance abuse problem is going to fall into the background. If it doesn't, then you've got to get more aggressive in your substance abuse treatment with the person.
Would you treat both either at the same time or the bipolar disorder primarily first?
You would treat the bipolar disorder first, because that's the main problem. I mean, you have to look at the person's history. I mean, if you have somebody who's been clearly a drug addict or an alcoholic from an early age, and then they develop bipolar, you're going to have to hit the substance abuse problem as intensively as the bipolar disorder. But in somebody like Mrs. Schenecker, who really hasn't had substance abuse problems until 2010, maybe 2009. I mean, she's almost 50 years old without really a history of serious substance abuse problems. So in her, you're going to treat the bipolar disorder and assume that the substance abuse problem would go away once you get the bipolar disorder squared away.
Now, was there a time in the records and in your speaking to Ms. Schenecker where you observed that there was the beginning of a downward spiral for Ms. Schenecker?
There's sort of two starting points. Starting around 2006, she started getting the paranoid symptoms, more descriptions of thought disorder problems. Then she goes into some manic symptoms. Then she comes to USF, and she's still having problems with some grandiosity, some paranoia. Then we're into 2009, and she's got delusions that there's cameras in the room. She's being filmed at home or watched as well on cameras. Then she really starts to go downhill around the middle of 2010, in July, when her antipsychotic medication is stopped. It's called Abilify, and she was on a high dose of that, 30 milligrams a day, and that was tapered off and stopped, I guess, around the end of June it would have been. So that's really the start of her rapid descent into severe mental illness.
Is there a possibility, or do you see in the records regarding Ms. Schenecker that her bipolar illness is getting worse over time?
Yes, there is. It's getting worse and worse by the year throughout the 2000s, from say 2001 till 2011.
And you said, I believe earlier, that there are a portion or percentage of patients that medication does not stabilize them.
Correct. One term would be refractory to treatment, or very difficult to treat.
When someone suffers from bipolar disorder, is it common or is it preferred that there is the therapy component along with the medication component?
It's as a general rule, it's always a good idea to have both, either in the same provider with the psychiatrist doing the supportive or talk therapy as well, or split therapy depending on the philosophy and staffing of the clinic.
At some point in the records, did you observe that there was a starting of tardive dyskinesia symptoms with Ms. Schenecker?
Yes. In 2010, earlier on in that year, she started getting the involuntary movements of her mouth, her tongue.
How did that progress for her?
It got to be very bothersome for her as the months went on in 2010, and the cause of the tardive dyskinesia is long-term use of antipsychotic medication. Somewhere around 5% of people or more a year who take regular antipsychotic medication are going to get tardive dyskinesia. Some studies show it's even higher than that, but she'd been on it pretty close to 10 years, so the odds were catching up with her that she was going to get tardive dyskinesia, and she did.
Is tardive dyskinesia something that you're familiar with?
Oh, yes.
And when someone starts exhibiting symptoms of tardive dyskinesia, and in this case with Ms. Schenecker, what was done in order to try to deal with that?
Tapering the antipsychotic medication is one approach to trying to deal with the tardive dyskinesia. The risk, of course, is that the person is going to have a return of their mental health symptoms, their psychosis that the antipsychotic medication is controlling. But on the other hand, tardive dyskinesia can become debilitating. It doesn't actually just stop with her having these mouth movements and tongue thrusting movements. So it's a terrible position to be in. Another option is to switch to different antipsychotic medication, and also to add medications to try to control it.
Now, you say the involuntary mouth movements. Were there other movements that Ms. Schenecker had that were affecting her in relation to the tardive dyskinesia with her legs?
Yes, she seemed to be having some problems with her gait, with her walking. And how much of that, when she was falling down in December, was from the tardive dyskinesia getting worse, or from changing her meds and her then being on lithium combined with anticonvulsant medications? It's really hard to say. But she did have some stiffness and lack of fluidity to her gait when I observed her as well in jail. It wasn't as smooth and natural of a gait as one might expect for somebody who was so athletic in her life.
When someone has the effects of tardive dyskinesia, is that something that can go away, or will it always remain even if you're taken off the medication?
Sometimes it will go away if you can stop the medication early enough. Other times it becomes a permanent condition that never goes away.
Because someone does have tardive dyskinesia, do they always have that every single day?
Yes, generally. It fluctuates during the day. It tends to get better or even go away when you're asleep. It can be worsened with stress or other medications that you take.
When Ms. Schenecker was taken off of the Abilify, or the Abilify was reduced, how did her mental health progress from there?
What you see in the records is that she seemed to start drinking more. There seemed to be more arguing and conflict at home. She began to feel like there was more problems, less support from her family. Then she began to get more depressed, particularly as we get into November, December. There was documentation of her having some trouble with getting her thoughts out. She would appear dazed. Her thinking seemed to be slow. So you could see the effects of the mental illness coming back more and more with time after the antipsychotic medication was stopped.
Now, the conflict that Ms. Schenecker was having with her daughter at that time, how did that affect her illness?
Well, it's the illness affecting her relationship with her daughter. I don't know that she necessarily has the insight to at that time to have understood that. I mean, she's reporting to the therapist that my daughter's being meaner to me, we're having more problems, but it's really the mental illness skewing her view of the world that's I believe causing the problems with Calyx.
When she starts the time frame where she's off the Abilify, or the Abilify is being reduced, and then she's starting to drink more, what did you observe about her records going into Winmore and her treatment there at rehab?
That she fluctuated in her insight. One day she would say, yes, I have a drinking problem. The next day she wouldn't. The next day she'd have insight again. She also had problems with depression. They put her on an antidepressant there when she was at Winmore, a Celexa, which is a type of antidepressant medication.
When she's at the rehab, are her medications changing again?
Yes. Yes.
And how is her mood at that time? How is she doing when she's in rehab?
She's having some problems with depression.
From the time that she gets out of rehab, from the notes at USF, is she still going to treatment at that time?
She is, yes.
And therapy as well?
Yes.
And how is her progress from the time that she gets out of rehab?
She keeps getting worse after rehab. You can just see her in the records getting worse and worse and worse by the week.
Now, when you have somebody that you're treating that's diagnosed with bipolar disorder with psychotic features, is suicide a common conversation that you would have with that patient? Her thoughts about suicide, if there are any suicide risks?
Yes, you're at a huge risk of suicide with bipolar disorder. 10 to 20% of people with bipolar disorder will commit suicide.
Now, throughout the records, is there indication about Ms. Schenecker being suicidal or her thoughts about suicide at that time?
Yes, but it becomes particularly a problem by the end of November when she told Beth Marsh that she was thinking of suicide basically on a daily basis.
And is there indication that Dr. Obregon is also doing some suicide risk assessments and that she's having vague suicidal ideations at that time?
Right, it's documented in his records as well.
When Ms. Schenecker gets out of rehab, does her condition ever improve from that time?
Not that I can see, no. I mean, she's described as pretty much starting to spend a lot of her time in bed. By December, particularly towards the middle end of December, she's described as feeling helpless, hopeless, worthless. She's doesn't have energy. She's sleeping a lot of the time. She's got a lot of guilt feelings that seem inappropriate guilt that appears to be related to depression. So she's pretty much getting all the signs of major depression.
When she's involved in this depressed episode, are there times when someone who's diagnosed with bipolar, with psychotic features, when you have a depression, can psychosis be associated with that, or psychotic thoughts be associated with that?
Oh, definitely, yes. It can be associated with the upswing or with the mania or with depression.
During your evaluation of Ms. Schenecker, did you talk to her about the shootings from January 27, 2011?
Yes, I did.
And did you ultimately reach an opinion about her state of mind at the time of the offense?
Yes, I did.
How do you come to the conclusions that you do? How do you determine whether someone is sane or insane at the time of the offense? How do you go through your evaluation process of that?
By reviewing the totality of the records, by my interviews with the defendant, by my discussion with them about the event that happened, by reviewing the information, the investigative materials, everything I can learn about what happened to try to put together from her as far as what her mental status was when it happened.
Did you, in this case as well, do some testing of Ms. Schenecker? Did you administer some tests?
Yes, I did.
Okay. And are the tests just part or a component of what you include in your evaluation of her?
Yes, that would be part of my routine evaluation, to do some psychiatric testing as well. I gave her, I guess it was 6 different tests as part of my evaluation over the course of my meetings with her.
Do you have an ultimate opinion about Ms. Schenecker's sanity at the time of the shooting of the children?
Yes, I do.
And what is your opinion?
That she was insane at the time that she shot her children.
Do you have an opinion about whether at that time when she shot her children that she was able to understand the difference between right or wrong?
No, I believe she did not understand the difference between right and wrong.
Can you explain your opinion to the jury?
At the time that she killed her children, Ms. Schenecker had a delusional belief that this was in the best interest of her children, that this was what was going to solve their pain, the dangers of the world. They were going to go together and be in heaven together, the 3 of them. All the pain and misery of life was going to end there. That this was God's will, that God was directing all this, and that she was doing what she felt was in her heart morally justified.
Did you take into consideration the writings of Ms. Schenecker, the journal that she wrote.
Yes, I did.
And how does that affect your opinion or your ultimate opinion in the case, the journal?
The journal in itself is interesting. I didn't see journaling routinely by her ever before, but what I think the journaling shows is her getting into a mixed state. I'm not sure if that's been talked about before, but some people who have bipolar disorder will get depression and mania all mixed together. So it's a dysphoric or sort of a miserable state of mania. And what we've seen in Ms. Schenecker before is when she's put on antidepressants, she can become manic and psychotic. And I think that's what we were seeing towards the very end, up to the deaths of the children. She was getting more and more of racing of thoughts, flight of ideas, more drive to do something.
Would that be consistent with the lithium that she was taking?
It would be consistent with her starting Celexa in November, and then the Celexa being increased to 40 milligrams. And then by the time this happened, she'd been on 40 milligrams of Celexa for weeks. So that would, in the past, that's caused her to have mania and psychosis, these antidepressants.
She's taking the Celexa from the time that she's in rehab?
Right.
And then that dosage is increased in December?
In December, she's given 20 milligrams as she comes out of Winmore. She's on 20. And then in December, it's increased from 20 to 30. And then in January, it's increased to 40 milligrams. Because Dr. Obregon is trying to aggressively treat her depression that's getting deeper and deeper, as you can see in the notes. They're trying to rescue her from going any deeper into this depression.
Well, she's at that point at a depression where she's been in bed for weeks and then is talking about suicide.
Well, yeah, she's in bed, she's suicidal, she's hopeless, she feels worthless.
And the Celexa increases her mood to get her towards a mixed state.
It's right. It's unfortunately not getting her into a good state of mind. It's revving up her negative thoughts. It's increasing her suicidality to where I think she was pretty much thinking about suicide most of the time she was awake towards the end. And then she becomes psychotic and becomes delusional, and she begins to lose her understanding of the difference between her and her children. They all sort of become in her mind one. Just like when she said, we are going to commit suicide. In her mind, they're all sort of this group that are connected, and we're going to heaven together.
And when you start seeing the psychotic thinking?
Well, you see it with the documentation in December of her being described as having guilt. That's a very common type of delusion that people get when they get severely depressed. They start feeling guilty about things even though they really haven't done anything to feel guilty about, but it's the way the brain works when you get depressed. And then in January, for instance, in Beth Marsh's note, she is slow in thinking and stares blankly and appears dazed at times. We see that in, I guess it's her last note from January 20th, I believe it is. So she's getting the thought disorder as well.
When you render your ultimate opinion that Ms. Schenecker is insane at the time of the offense, did you also take into consideration her statement to law enforcement?
Yes, I did. One of the things that she did, which I think is telling, is that she didn't try to cover up this crime. She didn't try to hide it. And when the police come, they said, where are the children? She says, oh, the kids are upstairs, almost as though she's speaking about them in present tense. And then she asks what day it is, because she's got to carpool the kids. And so she's not even connected with the difference between life and death.
When you see the photographs, when you're talking about her, not hiding what happened, were you able to see the notes that were on the door for the carpool? that will
Yes.
be back on Tuesday.
Right.
And what are your thoughts about that as far as how that ties into Ms. Schenecker's thinking at the time of the offense?
I talked with her about that, and the best she can understand that, and she has trouble understanding this as much as anybody, but to her, she thought it was the need to be together with her family and not have intrusion from outside people, that this was personal. It was a family thing together that they were doing, and didn't want to be disturbed or bothered by outsiders who weren't family.
Was there talk about possibly committing suicide through carbon monoxide at times?
Yes, there was, or by overdose.
Did Ms. Schenecker reference what she called a triple threat?
Yes, triple threat,
The
yes.
carbon monoxide, taking pills, and also shooting herself as
Yes.
the way that she would commit suicide.
She did, yes.
Do you have any thoughts or opinions about Ms. Schenecker purchasing the firearm on the Saturday and then ultimately shooting her children on Thursday?
Yes. Probably sometime on Saturday, possibly because she had a gun and she now had a way to painlessly and with mercy take her children with her, that she began to think about shooting her kids as well. I don't think prior to that she could have ever been able to do something to her kids that she thought would hurt them.
Now,
She'd always, in fact, not committed suicide because she didn't want to hurt her children.
What did she say about that in the past in the records as far as her children and suicide?
That was the one thing that had always kept her from trying to commit suicide, was how much she loved her kids and she didn't want to hurt them.
Was there talk, in the writings of Ms. Schenecker about not wanting to leave her children behind with the legacy of a parent who committed suicide?
Yes, there was. She also had the fear that if she left her children here, that they would be molested or raped.
What is your opinion about those thoughts?
Well, they're psychotic thoughts. They're not based on reality, but it's her own traumatic experiences feeding into her psychotic thinking, herself having been a sex abuse victim on a couple of occasions.
Is that something that she discussed with you when you interviewed her?
Yes, it was.
Did Ms. Schenecker discuss with you her feelings about her children at that time?
Yes.
What did she tell you about that?
That she thought this was the best thing, that she I'm trying to think of specifics in terms of that. She is there another way?
What was her
I have to.
relationship like with the kids? Prior to her having the strained relationship with Calyx in 2010, what was her relationship like with her children as far as she told you?
Well, that helps as far as the time frame. She, up until around 2009, she had always had a great relationship with both of her kids. In particular, she saw Calyx as being very attuned to her. They were like soulmates. Calyx could read her emotions, could tell where her mother was at. She'd always been, from what I can see in the records from other sources, a very devoted, loving, dedicated mother, the parent who the kids went to when they needed love, and the father was more of the person who would give them guidance and structure. So they complemented each other in their parenting style in that way.
When Ms. Schenecker purchased the firearm, what is your opinion about her desire to commit suicide on that day when she purchased the firearm?
She was planning, when she went to get the firearm, to shoot herself. That's why she said she was going to get the firearm. Once she had the firearm, probably on that day, from what she can remember, the idea of taking the kids with her began to come about. So the suicide became more, became a sort of an extended suicide in her mind.
And what ultimately prevented her from committing suicide on that day?
Ambivalence, mixed feelings.
Did she take the medication? When the police came, was she overdosing and on the back patio at that time?
Yes.
Okay. And at the time when Ms. Schenecker was being interviewed with law enforcement, did you ultimately receive records from Tampa General Hospital regarding what her condition was at the time when she was arrested?
Yes, I did.
And what was the state of her as far as ingesting medication at that time?
Well, she was interrogated, and then she was taken to Tampa General Hospital. Actually, she was interrogated, and then she went to the jail, and then she was taken to the hospital from the jail, if I've got that right.
And was she having an overdose at that time? Did she have toxic levels of medication in her system?
She had toxic levels of lithium in her system, as well as her blood thinner, Coumadin.
What is your thought or opinion about the levels of narcotics that she had in her system and her statement to law enforcement? How did that affect her, having toxic levels of Coumadin and lithium in her system when she's speaking to law enforcement?
Well, it's interesting that the detectives describe her as alert and oriented in their interactions with her, yet you can see what appears to be delusional thinking at the same time. So it didn't appear to be affecting her so much that she couldn't relate to some degree what was on her mind, even though she had taken the overdose.
When you look through the records, the Coumadin, was that something that she was routinely prescribed?
Yes, it was.
And what was that for?
She had a blood clotting disorder. That is, her blood was more easily clot to the point of causing problems. It's lead factor 5. It's a genetic mutation. So you're at risk of developing blood clots. So you have to take Coumadin to help prevent getting blood clots in your body.
What does Coumadin do?
It's a blood thinner, basically. It impairs the blood's ability to clot.
How does taking the Coumadin and that being a blood thinner affect her as far as the medication intake that she had for her antipsychotics and mood stabilizers that she was taking?
I'm not aware that there would be any interaction that I can think of between her Coumadin and her medications.
The Celexa that you were talking about her being prescribed at the rehab, that was a change from the medication that Dr. Obregon had her on prior to that?
Yeah, she hadn't been on an antidepressant medication for months.
No, in that year 2010 leading up to January of 2011, and consistently throughout Ms. Schenecker's records, did her medication change continuously?
In 2010, between January and December, she was on, or between, basically January to January 2010 and 2011, she was on 10 different medications with psychoactive effects. That is, effects on your brain, on your brain functioning, your mood, your ability to sleep or not, medicines for psychosis. So there was changes going on with 10 different medications in that 1-year period.
Now, as those medications are being evaluated, are they sometimes, the dosage is increased or decreased and sometimes discontinued?
Correct, yes.
How does that affect an individual trying to stabilize when their medication is changing?
We know historically when medications are changed, and Ms. Schenecker, it can cause her to become psychotic or manic or depressed.
What is the effect?
She's very sensitive to the biological effects of these medications, or her illness is.
And what is the effect of alcohol consumption or taking hydrocodone or oxycodone along with the medication that she was being prescribed?
Well, she'd been on these medications in various combinations since 2001, and she had been struggling on and off all those years without having any sort of alcohol problem or taking oxycodones or other narcotic medications, yet still was struggling during that entire period of time. So I don't see the oxycodones or the alcohol is really the issue here. I think that's sort of a non-factor in what happened.
The oxycodone that she had, or the hydrocodone, were those prescribed for surgeries that she had?
Yes, they were. I didn't see anywhere in the records that she ever obtained any sort of black market medications.
If I could have one moment.
Yeah.
That's what it is.
Why don't we give everyone about a 15-minute break? I'll remind the jury as I send them out to this break not to discuss the case among themselves or with anyone else, or to allow anyone to discuss it with them or in their presence, not to speak at all with attorneys, witnesses, defendant about any subject, not to read or listen to any reports about the case, not to do any research, gather information, communicate about the case with people or places involved through any means, including electronic devices. I'll let you step out for about a 15-minute company.
All right.
Jury's actually in the courtroom. Will counsel need to address this witness during the break? With that, sir, you're instructed not to discuss your testimony until you return to the stand. If you want to step down for a break, you may.